next speaker is Dr. Pradeep Ventrapati from Vizag, and he'll be talking to us about real-world outcomes of Pemetrexed-Platinum chemo plus Osimertinib after progression on first-line Osimertinib.
Good morning, everyone. I am Dr. Pradeep Ventrapati. So today I will be discussing the study real-world outcomes of Pemetrexed chemotherapy plus Osimertinib after progression on first-line Osimertinib in advanced EGFR-mutated NSCLC. We know from the FLORA-2 study findings that there was significant PFS improvement with the combination of first-line Pemetrexed Osimertinib to a tune of 25.5 months, which is the longest to date, versus Osimertinib alone. However, this was at the expense of increased toxicities, mainly chemotherapy related, especially myelosuppression. And also it required the patient to come every 3 weeks for intravenous infusions. So this led to an impact on the quality of life, leading to more healthcare resources and hospital visits. Hence, there was a real world hesitancy to commence chemotherapy upfront, both by the patients and the doctors. Coming to post-Osimertinib progression, there are already very limited options which we have seen. One of the option is platinum Pemetrexed chemotherapy with or without Osimertinib. And continuing Osimertinib beyond progression on Osimertinib is always a controversy, but there are, especially when there are phase 3 trials with first generation EGFR TKs which were negative. So now there is emerging evidence from retrospective studies which has shown that safety and efficacy of the combination of Osimertinib with chemotherapy after progression, and there seems to be a potential PFS benefit also. Overall, the data of the efficacy remains very unclear. So this study was done to evaluate the outcomes of Pemetrexed-OC following first-line Osimertinib progression in EGFR-mutated NSCLC in the real-world setting. The primary endpoint was time to treatment failure, and the secondary endpoints were OS, radiological response, and toxicities. So this is a retrospective multicenter cohort analysis spanning from July 2018 to September 2023. It was conducted at the National Cancer Center Singapore, Prince of Wales Hospital, and the Chinese University of Hong Kong. The patients who are histologically confirmed with NSCLC and advanced EGFR mutation were included in this study, and they had needed to have a documented progression on first-line Osimertinib. Any histological transformation after progression on Osimertinib was excluded. So a total of 60 patients were included in the study. Kaplan-Meier survival curves for TTF and OS were used to evaluate the TTF and OS. And the baseline characteristics in the study revealed a median age of 62 years, 53% were males, 76.7% were never smokers, and exon 19 deletion was 56 and L858R was 43%. Overall, 66% of the patients had already had baseline CNS mets, which was quite high. Coming to the outcomes with first-line Osimertinib in this study, the best response, partial response was 90%. Almost 54 patients had partial response, and 5% each had stable disease and progressive disease. The median time to treatment failure, that is TTF1, on Osimertinib was 14.4 months with a confidence interval of 11.7 to 17 months. The patients who had progressed, most of them had extracranial failure, 57 had extracranial failure, and only 10 patients had CNS failure. The lungs were the most common site of progression. So at progression, repeat molecular profiling was done for 27 patients, and 22 with a tissue biopsy and 5 with a liquid biopsy. Only one patient had an EGFR C797S mutation. Coming to the combination of Pemetrexed-OC after progression on Osimertinib, at the time of evaluation, 10 patients were still on treatment. The median follow-up was 31.2 months. The median TTF2, that is with Pemetrexed-OC, was 6.6 months. And combined TTF1 plus TTF2 was 23.4 months. The OS was 34.2 months. Here also, patients who had partial response or stable disease was 81%. Patients who progressed on this combination, again most of them failed extracranially, 47 out of 50, and only 9 patients had intracranial failure. Out of these 9 patients, already 5 patients had de novo mets at diagnosis, 2 had CNS mets on Osimertinib monotherapy, and only 2 patients developed new CNS mets on the Pemetrexed-OC combination. CNS outcomes at Pemetrexed-OC initiation, they found that there were 43 patients who already had CNS mets, and out of that 34 patients, that is 79% had stable or responding CNS disease, and 9 had progressive. And brain imaging was performed by the initiation of this chemotherapy plus osimertinib, and out of that there were 32 patients who had measurable CNS disease. 5 patients also received prior radiotherapy, and out of those 32 patients, again 31.3, that is 10 patients had complete or partial response after starting chemotherapy again. Only 3 patients had progressive disease intracranially, and also 3 of 4 patients who skipped radiotherapy also achieved partial response or stable disease with chemotherapy. Subgroup analysis based on the mutations, both the mutations were comparable, either with TTF or OS. On multivariate analysis for TTF2 and OS, the significant predictors of improved TTF2 mainly were time to chemotherapy initiation. Those who had chemotherapy initiation within 20 days of progression had a better survival, a better TTF2, and also patients who had partial response and stable disease had a better TTF2. For overall survival, the TTF1, if it is more than 12 months, they did better, and patients who had baseline liver mets did worse. So the authors found that Pemplat OC is effective after osimertinib progression. The intracranial control is also very high, of 90%. The outcomes were comparable across all groups, and early chemotherapy initiation is critical for improved TTF2. So the study strength is that it is the first real-world multi-center data set and demonstrates efficacy for chemotherapy-eligible patients, but it's a retrospective study design and small data set. So my take is that first-line osimertinib alone is very convenient for patients with a good QOL and reasonably good PFS. FLAURA2 is yet to show OS benefit. Amivantamab is associated with high cost, toxicity, and availability issues. Use of Pem-Platinum with OC after progression on first-line OC also seems to show similar efficacy as we saw. So this approach should be considered strongly to at least avoid unnecessary chemotoxicity for a major part of the patient's life. Thank you.
Thank you very much, Dr. Pradeep.